Okay, I think that's 60 seconds. So let's welcome everyone and get started with it. So for those of you just joining, my name is Tom Arnold. I'm CEO of Gridium. Excited to have Larry Schoen on today's webinar discussing early ASHRAE guidance for building operations during
Good morning to
COVID-19.
those on the West Coast.
Thank you. Thanks for joining. Okay, what are we going to cover today? So a couple of things. Mainly, I'm going to just give a sort of instructions and set Larry free. Most of the topic is about the early guidance and how ASHRAE is viewing this and considerations for non-medical buildings. And I think the office is the primary attendee of today's webinar, although we welcome your comments sectors. This is an open discussion, so I know that we're going to have a ton of questions. On the right-hand side of your GoToWebinar panel, there is a question or chat box. Just lob your questions in there. We'll QB them and should have a good amount of time for questions at the end, so we can get a good discussion going. Great. So I think a lot of people know me. I'm Tom Arnold, CEO of Gridium. Larry, you're new to our community here. Larry Schoen is a very distinguished and accomplished building professional. He's got extensive experience in buildings, and particularly related to air quality. The author of numerous position documents and chairships and vice chairships at ASHRAE. Larry's been also a key principal in the COVID discussions among the ASHRAE community. And what I really like about Larry, and thanks for joining us here, is that Larry's a former building operator. So Larry had a good run at Roos on the East Coast and has run every type of building there is under the sun. So Larry's been in your shoes before. This is not just a sort of academic blue sky approach to things. I think Larry has a great amount of empathy for the variety of systems and budgets and constraints that we're all under, trying to manage this. With that, Larry, I'll pass it off to you, and let's hear from you about what the state of the science is, what is the role of the HVAC system, and what are the considerations for reopening.
Sure. Okay, thank you. So I guess, as Tom mentioned, it's the first bullet that I feel makes me sort of empathetic and able to lead this discussion and the beginning of the discussion. And the rest of the bullets tell you about my activities with ASHRAE, and the second bullet is basically what my company does right now. So on the next slide, we'll start right in with the depending on who you ask, opinion. I believe the HVAC system has a relatively small role in all of the infection control things that you're going to do, whether it's in a healthcare or in our type of non-healthcare building. So what do we know? You know, this is they keep calling it novel. It's a new virus. So a lot of what we know comes from the previous SARS in 2003. And other viruses to some extent, but they all behave a little bit differently, especially with things like viability on the surface, viability in the air, sensitivity to temperature and humidity. So we think I believe, and I don't think anybody would argue with this, it's going to take years until there's a scientific consensus, and that can then filter down into maybe some more specific valuation of what the interventions are that are important in buildings. So on the next slide, we will see the basic chain of infection as given by the CDC. And I guess I'd call your attention to first of all, the reservoir on the left side, which in the case of this disease, usually it's a person, and then it goes through these intermediate modes of transmission. And for the purpose of the HVAC system, it's the two that are almost at the head of that arrow, the droplet and the airborne, that are the only two really that we can do much about with the HVAC system. So on to the next. Furthermore, we all have some resistance. Just because you get a transmission from the person who's infected to the person who's susceptible does not always lead to infection. And then, of course, as we know from this disease, even if there's infection, it doesn't mean you even know about it. It might be asymptomatic or very lightly symptomatic. So these 4 bullets kind of give you the general overview of the ways to contact. The direct contact, of course, nothing the HVAC system is going to do. The inanimate is why you do the other actions in the buildings. And the last 2, the large droplet and the aerosol, are the ones that even the best HVAC system can influence only those.
Larry, let me just pause here for a little bit, because in our last webinar, we talked about some of the emerging science here, some of the studies that literally are coming out every day, largely on preprint. And it does seem that there's a lot more focus on droplet transmission, which is why we have the social distancing type rules. And yet the ASHRAE guidance uses the term substantially likely in terms of the air conditioning system's role in transmission, which I found a curious word choice. Can you say more about what the position is, and is it that we're trying to just assist, or do we believe that this is fundamental vector of what's going on? I mean, where is ASHRAE falling out in terms of the discussion of this, or do we not have consensus? It's a question of the science is not ready yet.
I think where there's more of a spread in views is on the nuance of it. I'm not aware of anybody who really thinks that it's a major mode of transmission, that the infected person's breath goes up to the return inlet, goes back into the HVAC system through the coil and the filter, comes out and infects person B. I don't think that's it. So it's more the one you said, acting as a preventive mode. So let's say we can't maintain the 6-foot different distance. More ventilation, more dilution is going to be better. Even at the larger distance, we're still in the same room. I mean, remember the days of smoking rooms? So the smoker could be on the other side of the room. You still smell it. You still get the contaminants, no matter how perfect the filtration in the air handler. So does that answer the question?
Yeah, no, I think that's exactly what is interesting here, is trying to interpret this guidance, and especially for your frustrated building operator here, they're hearing all kinds of different things, and you can literally read the document and make different conclusions depending on how you read the sentences in the document. So I think that's one of the things that is great to have you on as someone that can reinforce that.
And I just want to say it's overwhelming for me, and I'm trying to stay up to date. Okay. Yeah. There's so much coming out day to day. So what do? If you don't know which is the primary mode, I think the answer is you do what they call in the hospitals a bundle of interventions, and the HVAC is only one of them. So let's see a little more about specifics on that. And here's the basic dividing line between large and small. Depending on whom you ask, that's going to be at a different size particle. It might be as low as 1.5 microns. It might be as large as 10 microns, so depending on whom you ask. But the exact size demarcation is not what's important. What is important is the smaller ones, and there are going to be some smaller ones, will remain airborne. And so they can go over a longer distance. The larger they are, the sooner they're going to settle to a surface. That doesn't mean they're dead as soon as or out of the picture, because things on surfaces can do a couple of things. One is I can touch that surface. And the second thing is it can be re-entrained into the airstream in some circumstances. So my friend and colleague Hugo Lee from Hong Kong says that, getting back to that droplet issue, yes, the droplets are generally going to settle to the ground in 1 to 2 meters, but also think about the fine aerosols that might be coming out of my breathing those are also in a higher concentration. And if you think about a cube, that's concentration of those fine things are going to go down as the inverse distance, inverse cube relationship. So that's pretty
Hmm.
drastic. 6 feet, and
Yeah.
that's another reason for the 6 feet.
Yeah.
So this one gives you some idea of size. So you see a human hair, you see a fine grain of sand. That proximate size range for the demarcation that I've mentioned, about 2.5 or 1.5, some say, to 10 microns. The red one is 2.5 microns. The blue one is about 10 microns. So these are pretty small particles. The virus itself, I want to tell you, is more on the order of 0.12 on average microns. So it's like half, I'm sorry, 1/20th the size of one of these smaller ones. But the thing is, the virus never travels alone. It's always traveling on a droplet of salt, water, and mucus. I hate to be explicit, but that's what it is. So on the next slide, you see why is this important? Why is the size? Oh, okay, it's a later slide. So here's what we mentioned before. It can remain viable on the surfaces, but that doesn't mean if it's there in 72 hours that it's just as strong as it was at hour 1. This is an exponential decay. So that's good news for us. The bad news is if I touch the surface right after you coughed on it and you're infected, and then I do what we all do automatically, which is touch something that's a mucous membrane, then I'm exposed. If you think about surfaces in a building, what's the biggest surface around me? It's not the desktops, it's the floor. So not surprisingly, when they had these little robots running around the hospital picking up samples, they found the highest concentration on the floor. Not so surprising. And here's the issue. As you walk on the floor, as you clean it, maybe even as you sweep it, if it's dry sweeping, there could be a re-entrainment of what's on the floor into the airstream. So all that could be significant. Next slide. So the basic, the stuff that's not the icing on the cake, the basic cake itself. Of course, keep people home who can stay home. So to some extent, buildings will have to open. That disinfection that we talked about, hand sanitizer dispensers and product, assuming you can get it. And then I think if I were opening a building, I would say to everybody, let's close off frankly the conference rooms. Let's have our meetings if we have them in a large open area. Let's close off the community food and coffee places. Bring your own food, water, and coffee from home. So let's go to the next slide. And then of course there's the whole issue of education. I saw a really neat slide on the New York City subway system. It's got arrows, one this way, one that way. And it says essential workers this way, non-essential worker. Why are you even here reading this?
Yeah. I did see that. That was
So
very, very well done.
kind of a lighthearted but in your face way of educating the public. So maybe those of us who are more creative can think of ways to emphasize these individual behaviors. And of course, the most important thing, if we're in any position of authority, is to model the behavior that's recommended ourselves. When people get on the airwaves and they say we recommend a face mask and they are not wearing one, it just doesn't send the message.
Yeah.
So I'm not making an opinion about yes, face masks, no, but when we say something, we need to model it, not just say it. So I think we can go to the next. And this kind of drives home the same point. Some of the old evidence from 03 on the previous SARS did show that the aerosols could travel. In fact, from one high-rise residential tower to another, exacerbated, by the way, by empty plumbing traps. So there is that's why, the organizations are being cautious, and they're saying, it's plausible. There's a high level of plausibility. And the aerosol's been detected recently of the SARS-CoV-2 in hospitals. But I still say the direct contact surfaces and large droplets, close proximity, or the high concentration even of the small particles, drives the hygiene, the distancing, all those basic things, and brings us now to the HVAC system. So non-healthcare. I'm not talking about healthcare. That's a very specialized occupancy. Increasing the outdoor air ventilation, what does that do? Inside the room, if you think about the old tobacco smoke analogy, if you're bringing in more outside air that doesn't have the contaminant in it, in this case, the contaminant is the potential for an infected person. And by the way, this is a risk management calculus that you sort of have to do. How high is the risk in your occupancy? Is it a known population of regular people who are going to be cautious about if they're experiencing symptoms? Or is this a place that's open to the public where you don't know who's coming in? So all these drive the level of risk and maybe your intensity of intervention in all of these interactions. So if I had a demand controlled ventilation system, I was just talking to a bunch of operators, they said, we've got these Lennox rooftop units, and just to change the demand control ventilation setting, I've got to go to every rooftop unit. Well, hopefully you're lucky and there are 20 or 25 ton rooftop units if you got to go to each one. But if they're little 5s and 10s and you're changing that, that's a big hassle. But that is something I recommend, because if you've got a demand controlled ventilation and a lower population in the building, this is not the right time to exercise, in my opinion, that energy saving strategy. This is the time to save lives and save health. Did you have a question, Tom? Or no.
No, I was going to say,
Oh,
I was only going to say that, Gridium customers, of course, know how much they're saving in COVID operations, and that runs a gamut. But we've seen anywhere from 15 to almost 50% reductions, even though the building is operating under the lease conditions. So I would put your context of your DCV strategy in context of sort of what the total budget looks like, and we can help you with that math in doing those trade-offs if you want. I think the other concern on outside air is, can I really do it? Especially if we've been having some weird weather patterns in the Bay Area that actually aren't in the weather record, like 108 degrees in downtown San Francisco, for example. So there are going to be days like that where you can't pull out all the stops and deliver the comfort services that you need to.
Right. Go back one slide. I'm not sure if I got everything that was on that one. So given that you maybe can't always bump up the level of ventilation, but running up the hours is probably more possible, and then reducing the building population, disabling the demand controlled ventilation, which increases the effective ventilation per person. That's a strategy probably more accessible without straining the capacity, as you said, on these systems with extreme conditions.
Yep.
So we're going to touch a little bit more on the filters, but these are some recommendations for sort of smaller air handlers as well as for larger central systems. And there's the longer run time. Humidity, I don't think that's going to be low humidity. That low is an issue in your Bay Area or most areas of the country this time of year. That's more an issue in the winter time. And I don't recommend doing 30 or 40% humidity year round. I would say that's an emergency intervention for certain buildings, if you even have the capability, and many buildings in the cold climates do not. And the portable filters, that's a possibility. If you don't have adequate filtration or you want to bump it up, freestanding room HEPA filters will decrease the intensity of the fine particulates inside the room.
And a lot of that we've had also a lot of our customers on the webinar are Bay Area, and of course we've had terrible wildfire episodes the last 5 years with very high particulate matter coming in. So that might be something to consider just in terms of indoor air quality.
Mm-hmm. Yep. So let's look at those filter ratings. So there's a busy chart on the next slide, but if you move your eye to the left side where it says MERV level, and let's say you go to the MERV 8, which is a pretty common filter size, and follow along to the right-hand columns. And remember those numbers about the particle sizes I mentioned before of 2.5 to 10. So you'll see that the MERV 8 doesn't even have a rating until you get to the higher end of that, 3 to 10 microns. And it's filtering out 70%, which is okay for those larger ones, but not even a rating for the smaller ones. And why are the smaller ones important? They may have less mass in total, but they're also able to get deeper into the lung, which is a health issue. So now follow your eye to the MERV 13 on the left-hand column, and then follow along to the right. And you'll see we start to have a rating now, even at the very small sizes. 0.3 to 1 micron, we're now removing 75% of that, and a much higher percentage of the smaller particles, greater than 90%. So that's the rationale behind recommending these higher MERV level filters. Does anybody know end-to-end in a commercial building what the reduction in infection rate is going to be from that? Nobody's done that kind of controlled study. It's all inference from the basic science and physics. So on the next slide, this is an example taken from a residence, but a couple of principles here. One is that, excuse me, the room air cleaner is just that. It's for a relatively small area. And secondly, what this illustrates is you put it in the place where people are spending most of their time to get the greatest benefit. Now, again, if you looked at this residence, this is, you'd have to believe you're in a residence where you think one of your housemates is infected, and that's what you're protecting yourself from. So if you kind of use your imagination to think of this as 3 enclosed offices, or maybe 3 stores in a mall, if you didn't know what was going on in the other rooms, you might want to protect yourself in your own room. That's what. That's the basis of this one. So on the next slide are some precautions. There was some advice coming from various parts in the world. Shut the HVAC system down. Neither I nor ASHRAE recommends that. If your system has the basic features of bringing in some outside air and mixing it with recirculated air and doing filtration. If you're doing that, then you're delivering with that HVAC system cleaner air to the room than is in the room, assuming there's, again, a source of potential infection inside the room. In some rare case, if you've had an infected person, yes, you could be spreading it from one area to another. We haven't seen that documented yet, but so that's kind of an outlier situation. But certainly if you've had a room with an infected person or a building, I would disinfect it and include the HVAC system in that. Again, if your system doesn't have the basic field features of outside air infiltration, like there was a report done of a restaurant in China that had basically recirculating air, then maybe it's not a good idea to just run that recirculation system that's moving the same dirty air around. And then, of course, the major outdoor contamination, which I don't think is a problem in most areas of North America, particularly with the silver lining of lower pollution levels because of decreased economic activity outdoors. Don't over humidify in the winter. That's really a cold climate issue. there are products being marketed that claim to be electronic air cleaners or electric air cleaners. I would use caution in anything that's not a standard technology like a MERV rated filter. I think that's beyond that, where you get a manufacturer claim that can't be verified by a third party, where they don't have necessarily a UL certification, that it does not release ozone. Ozone is a lung irritant. So although it can get rid of odors and make you feel that fresh after a rain sensation, it's a lung irritant. And reducing lung health is not something we want to do right now.
Yeah. How would you put, I know we talked about this on our last webinar as well, but how would you put sort of UV, in air handler treatments of UV technologies, ionization, that type of stuff? Is that something that people should be researching, or you're thinking that's not a key part of the response here?
I don't think it's a key part of the response for a typical building. For high risk occupancies, there may be some. So let's take them one at a time. So the induct or in air handler UV, that has been shown to be good for keeping the coil clean and reducing pressure drop in the system. It has two problems with keeping the room disinfected. One is the air is moving at 450 or 550 feet per minute across a coil. That's not a very long residence time to get the kill rate that you need in a relatively small space inside an air handler. Second limitation is, even if you had a great kill rate, you're still limited by the air changes in the room. So you can get a pretty good rate. Remember those MERV filter ratings? You can get pretty good removal even with those, but you're still limited by the air distribution in the room. So for a high risk occupancy, what do I consider high risk? So certainly some healthcare occupancies. To my mind, a transportation waiting area where you have people coming in from all over places and you don't know their status of infected status or non-infected, that's high risk. Prison, certainly, high risk area. So this is a strategy irradiating the upper reaches of the room, above 7 or 8 feet, with ultraviolet. Why upper? So it doesn't affect me. The ultraviolet is damaging to the skin, the eyes. So we don't want to shine it on people. We want to shine it on the air. This can be effective, and studies have shown can achieve the equivalent of 3 air changes or so an hour just by doing this.
So you might consider, I'm thinking of some customers that have, direct connection to BART under the building with, huge crowded passageways. Is that kind of where you think this technology is appropriate in terms of the high risk?
I guess I consider it high risk if it's an unknown population in that area. So if I have,
yeah, it would be. I mean, it's everyone getting off BART and coming up to the station through an office building provided vestibule kind of area.
Yeah, I would, and so first thing I would do is try to keep that air out of the rest of my building.
Yes,
it's unknown quality. So
yeah.
and that's tough. If you can find a way to do it with pressurization or exhaust in that intermediate area, pressurization of your clean area. You always want flow from clean to dirty, so you keep the clean clean. The other issue you have is if it's that same population that's in the rest of the BART, it may be too late by the time they get to that spot.
Public transport is one of the things that's definitely going to change, isn't it?
Oh, it's tricky. It's tricky. I actually was writing an article about that right now, and it's very tricky to maintain social distancing on those, or on something like any kind of transport, like an elevator, vertical transportation. That's a big challenge. Yes. I don't know what high-rise buildings are going to do short of the other stuff like screening people really carefully. So this is an example. I can't tell you how old this photograph is. I think it's in the ASHRAE handbook of applications. But those fixtures that you see right below the grills on the sidewall, those are UV GI irradiating the upper reaches of the room. And the fixtures themselves have some baffles so the beam doesn't get on the people. So this is a high risk minority of spaces. So let's see what's on the next. Yes, I have one site under construction where they have not repeatedly, they've found people infected and they've had to shut the construction sites down and disinfect them. So I don't operate a building right now. I have the luxury of keeping up with the research and staying in my office. But if I had to go make some observations on a construction site, I would consider ways to do it without having to visit. Make that the last resort. So if presence is unavoidable, take those precautions. So for people operating the building, a lot of what I've given has been general advice. It really helps to know what the system is that you have in your particular facility and how the facility is used, what's the public coming in, where are the risk areas. And, it's sad to say that as we start to open buildings up, we are going to have infections. There is going to be transmission. This disease is not under control. So I think it's important for everybody to recognize, whether it's the public, a building operator, a tenant, that we are all, those of us who are interested in doing responsible actions, we're trying to do our best, but we're not going to be able to eliminate all risk. The HVAC system is, as I like to call it, the icing on the cake, and it's not the primary mode of infection control. And there's a lot of guidance out there, maybe more than we can handle at the moment. So I might have a summary slide coming after this. Let's see yes, that's right. So the icing on the cake metaphor, and keep those systems running, keep the outside air and the filtration. Lengthening the hours is a good way to keep the spaces clean. Humidity, again, that's going to be more of a seasonal thing that'll come into effect perhaps if we're still fighting this in December, January, and into the winter months in the cold climates. There are advanced techniques available for those crowded spaces of high risk. So I think on that note, we can open it up to questions or discussion.
Great summary. Really like it. We do have some questions coming in. I'm going to sort of QB them and put you on the spot. If you're interested in your particular situation or how your organization is responding to this, it's an open playing field here. So please type those questions in and let's get them rolling. Okay, let's talk DCV. So a lot of questions on labeling DCV. One of the particular questions is, wait a second, DCV, I'm blowing more air. Is there a concern that lots of air movement here is not what we're actually aiming for, especially if we believe that there's droplets on the floor? Is there a balance here of more running through the space versus fresh air, clean, uncontaminated air coming through the space?
So let's take a step back. So for demand controlled ventilation for a mixed air handler, in other words, one that's not a DOAS, a dedicated outdoor air system, for a mixing air handler, generally those are not increasing the airflow in the room. They're increasing the proportion or decreasing the proportion of outdoor air in that mixture. So there I don't see the room issue at all being a factor. On, let's say, a DOAS system where you might be cutting back, it's still a relatively small portion of the overall circulation in that room. And so is there the potential of blowing air? Yeah, if somehow you had a sidewall air diffuser blowing right at me and I'm the infected person and you're right behind me and you're the uninfected, yes, I could conceive of the situation. But most of the time where it's
So it depends
above,
on,
yeah, if it's ceiling the air distribution or high sidewall air distribution, or even displacement from the floor, I think the benefit of the additional dilution far outweighs any risk of air movement being a problem in the room.
yeah. Two space related questions there. What about conference room DCV? These are popular in lots of office buildings and corporate spaces because you know the conference room is of course sized for maximum capacity. And then a question about parking garage DCV. What about that issue?
All right, so let's take them one at a time. So first of all, you already
Yeah.
heard my view about the conference room. Close the conference room. If we're going to have lower occupancy in office buildings, then there's going to be lots of space. If it's not a confidential meeting, have it in a large open space where there's much more breathing room, quite literally,
Hmm.
and more ventilation per person. If you had to have a confidential conference room, I would still try not to load that conference room up to capacity. That's not going to be maintaining social distancing. Um, and
Yeah.
again, I would try to disable the DCV there. So my first preference would be don't use the conference room, close it up.
Yeah.
On the parking garage, so I know that some of the modern ones have a certain amount of air circulation all the time, a certain amount of exhaust, and then they bump up into high speed when there's a carbon monoxide incident.
Yeah.
I don't personally view a parking deck as a high occupancy, high risk area. I would worry more about the parking garage elevator
Yes.
or lobby.
I think there's an area of focus there for sure. Yeah, I mean, I can't imagine a high occupancy parking garage, especially in these early weeks and months of reopening. Okay, very helpful. Okay, there's more questions coming in here. Coming back, so another question: UV lighting in the air handler or an air handler with bipolar ionization. These technologies. This is the sort of in air handler treatment intervention. What's your opinion of those? Are they appropriate for certain buildings, and if so, where? What kind of buildings are they appropriate for?
Okay, so let's take those one at a time. With the UV, first of all,
Yeah,
UV in air handler, as I mentioned, the primary benefit that's been demonstrated is it keeps the coil clean and therefore reduces the pressure drop in the system. It's basically a cleanliness and energy conservation intervention. It's not the primary intervention, in my view, for disinfection of the room.
hmm
You don't need it for that purpose.
yeah,
The ionization, bipolar, whatever it's they're going to call it, because there's
yeah,
a lot of names given to these electronic and ionization systems. They're not rated to a particular standard for effectiveness. They're usually based on manufacturer claims. If you must, I wouldn't use one myself. I would stick to basic technologies. If you do use one, make sure it's rated to the UL standard for not releasing ozone.
yeah, because you're worried about the long irritant by uh, byproduct of that technology.
Just to give you a graphic thing, when you know in the there used to LA area, okay, the basin used to have
Yeah,
much higher levels of air pollution. You can still track emergency room admissions of asthmatics, those with sensitive lungs, with outdoor ozone levels. Outdoor ozone level goes up, emergency room admissions for asthmatics goes up. It's a lung irritant. Stay away from ozone.
yeah, yeah. My daughter is asthmatic, so very sensitive to that topic. Okay, another question here. Could you please clarify the particle size microns that should be targeted for filtration-based uh, reduction? if we can have the MERV filter slide, that might be a helpful exhibit to just go through this one more time.
Sure, sure. So I'd like to say that we know the exact particle size that's going to affect people, and I'd like to say here's the concentration that we need to remove in order to protect people, but we don't have hard data like that. So it's unfortunately, well, it's just the way it is. It's on a sliding scale, so to speak. The smaller the particle, the longer it can stay airborne. The smaller the particle, the deeper into the lung it can get, and so therefore the more dangerous. So we want to do the best job we can do with the smaller particles. MERV 13, it's a judgment call. It's a judgment call on product availability, reasonable pressure drop, and pretty good removal. So if you look at the chart from 13 to 16, you see it's, you know, it's at least rated, and it's up there in the higher percentages of removal rates in those ranges that we care about. Remember, so we're looking at this first column, 0.3 micron. Remember I said the virus itself is 0.12. I think it ranges from 0.08 to 0.16 or something like that. So
yeah,
so it's smaller even than the 0.3, but it never lives alone.
Yeah,
it's in a water droplet with mucus and salts. So you're going to be able to capture a lot of it, even at the smaller ranges, with this MERV 13 filter, and that's one of the reasons we recommend it.
but is it, you know, if the management is asking a building engineer or the owner is asking a building engineer, I don't care, just get rid of this completely in the air handler. Is there a magic bullet here? I mean, even at MERV 16, you still have a risk issue.
Well, even the most magic bullet is not complete. So a HEPA filter is
Right.
99.7, removes 99.7% of the 0.3 micron. So that's the lowest level of the left-hand column. And even if you remove it at the air handler, you are still limited by what's happening in the room. So when we used to struggle with the tobacco industry, they could say, we can get everything out of the air with a HEPA filter. I said, well, that's great. You can do that. But I'm not with my nose up at the air outlet at the ceiling. I'm down here in the room with the smoker. So whatever you can do at the air handler, it's still not protecting me and removing it completely at the breathing level.
It's back to the icing on the cake, because the issue is actually in the room itself. Very interesting question, and thanks for that explanation. Okay, another one coming in here. Can you talk about the humidity some more? What is the concern here? And I guess there's two parts of it. One is if this is prolonged and we come into winter cold climate, and we do have some cold climate folks on the webinar here. You know, why this 40% threshold, and what is the concern with raising that prematurely?
All right, so do we want to take a step back to why is low humidity a problem?
Yeah, I think that's the gist of the question coming.
All right. So low humidity is a problem because it does seem to be associated with higher transmission of diseases in general. And there are three possible explanations for that. One is at the droplet level, the lower humidity allows the droplet to dry out faster and therefore become smaller. And as we said, the smaller it is, the more it can remain airborne. Second one is with susceptibility of the person. Drier mucous membranes seems to make me more susceptible to getting infected. And third is the viability of the organism itself. That's not universal. Some organisms do seem to do better at lower humidities and some don't. And I have seen the preliminary information start to come out on SARS-CoV-2, and it does seem that there's evidence that it's better to have slightly higher relative humidities. Mm-hmm. Now, if there's an overnight low, I'm in Calgary and there's an overnight low of negative 20 degrees, well, they use centigrade up there, but let's say it's negative 20 degrees Fahrenheit. I may not even want to go close to 30% because I'm going to have moisture problems in my building envelope and other cold surfaces. So this is a very tricky one. On balance, I generally don't recommend humidification for buildings because of all the risks. If I had a system in the midst of this emergency in a really cold climate, I would use it, but with great caution.
Yeah, yeah. You certainly don't want to dig yourself a bigger hole than the one you're already in. Okay, a question here, back to this elevator issue, and then there's also a bathroom question. These are the problem spots, and it seems, and I think the question is basically common bathrooms, not behind the tenant side, building operator. What are your thoughts here?
So, I did some preliminary calculations on the minimum size elevators required for ADA. So there are two sizes depending on whether the doors are center opening or whether they're side opening.
Yeah.
And they're right on the borderline. The one, I forget which one is a little smaller, but the one that's a little smaller, you couldn't even get a 6-foot separation with two people on the elevator. The one that's slightly larger, you could just barely maintain it if they crowded themselves in the corners of the elevator. So this is a tricky one. I think the advice from the public health experts is if you can't maintain the social distancing, that's when you wear the mask.
Mm-hmm.
So that might be one strategy.
Yep.
Maybe limiting the population in the elevator. Certainly wiping the surfaces of the buttons is a good idea. I guess the one thing we have going for us in the elevator is hopefully it's a pretty short ride, and there does seem to be a dose response relationship.
Yes.
And that means,
Yes, I think that's very clear from the healthcare research. Yeah, unfortunately, our frontline workers are the ones that are getting massive dose after dose after dose and suffering for it.
right, so that transit operator that we mentioned, who's got to be on the bus for a whole working shift.
Yeah. Yep.
But I did see one study of a bus in China where it was a 100-minute round trip, and the one infected person on the bus apparently infected, from memory, about 24 of the 67 or so people on that bus in a 100-minute trip. So risk for the riders too.
Yeah.
On the bathrooms, fortunately, at least in bathrooms, there is a pretty good air exchange. There's a continuous, usually continuous exhaust. I guess that's what I would do. Is I wouldn't keep it on intermittent light switch exhaust. I would try to get that fan running constantly.
Yeah.
Even though it's going to cost a little bit of energy right now. And I want to say reduce occupancy in there. You would try not to have events where everybody's got to go all at once, if you can avoid that.
Yeah.
And then, of course, the surface cleaning. That's probably the bigger thing you want to do is surfaces.
Yep.
And wash your hands.
Great. Okay, we've got a minute left here. Any remaining questions, please get them in the question box, and then we'll wrap up here. One other area of interest here is lobbies. What do we do with lobbies in our buildings? That tends to be where you get the crowds. What are you seeing out there in terms of lobby treatments?
I know in China when they started to, or I shouldn't say China, in Asia, various places in Asia, when they started to open up buildings, they did have surveillance of people coming into the lobbies, and everybody had to be wearing a mask. They were checking for temperature. No lingering in the lobby. It's a pass-through area. Get through. And go along. Now, what you do with the elevator issue in conjunction with that, I don't have a solution to that one.
Yeah. I think many of our buildings have invested in these beautiful lobbies that are public meeting spaces and have good furniture and have publicly accessible Wi-Fi, and that seems like a risk area to me that needs sort of thought about changes in operations for those beautiful lobbies.
Yeah.
And I think the public will understand that coming back.
Yeah, I think people, I mean, right now, I think people should be, if they're lounging, they should lounge at home.
Yeah.
And the one thing we
That's
have
it.
going for us is a lot of these lobbies are high ceilinged.
Exactly. Yeah. Yeah. That's right. Okay, well, good. I think we're going to wrap it up there. Thanks for all the questions. Of course, you can contact Gridium. Larry, your email is in this presentation as well. We'll send it out if people have additional questions for you. I'd just like to close by thanking you. I think it's very difficult to be tasked with running a building and reading all the medical research. Yeah, that seems to change almost day to day, and I think you've helped to orient everyone to strategies that make sense, and how the HVA system is kind of the icing on the cake. So thank you for that.
Yep.
Any closing thoughts on your side?
Just thanks for the conversation, and I always learn from the questions as well. So thank you for that.
Great. Fantastic. We'll distribute the recording and the slides. Thanks, everyone, and enjoy the rest of your day.
Take care.